Greetings to everybody on this hybrid meeting. So greetings to those of you in person and those of you online. Thank you so much for inviting me. My congratulations to the organizers, especially Professor Galangos. I feel that this is a hugely important forum, and so it's a real pleasure to contribute, even though I wasn't able to do so in person. So I work now for the South African Medical Research Council, and we recognize the persistent consequences of colonization on our continent and apartheid in our country. And we commit our capacities and resources to the promotion of justice and dignity in health research in South Africa and beyond going forward. This is critically important when we consider the conversation that we're having today about humanitarian fora. We know that congenital heart disease is a structural malformation of the heart, the valves, or the great blood vessels. We also know that it's the most common birth defect in the world. But interestingly, we're also recognizing that the prevalence is increasing over time. There's a predominant genetic etiology. And as the prevalence increases over time, so too is the prognosis. But in Africa, data are lacking, emerging, and very different to what we see in the rest of the world, especially in the global north. If we look at this now slightly outdated graph, we see that the mortality rate per 100,000 individuals are the highest on our continent and on the Indian subcontinent as well. If we look at the specific numbers, we see over 200 deaths, 200,000 deaths globally, over 13 million prevalence, and 80 million deaths. But the most important numbers are the two at the bottom, that 96% of those deaths are happening in low and middle income countries, and at least 70% of those deaths were in infants. This is a really poignant paper for those of us living on our continent or in low and middle income countries in the world, where there's a discussion about the survival of children with congenital heart disease having potentially reached a peak at 97%. This is obviously focused on the Scandinavian countries, this paper, but also really a issue that is only facing, or this question, have we reached a peak, is only facing those that live in the global north. In the global south, it's very different. This is a review of the papers from van der Linde that is quoted so often, where it seemed as if Africa actually didn't have an issue of congenital heart disease at all, with a prevalence of 1.9 per thousand live births. We were able to refute this somewhat in a later paper, which suggested the number was closer to 2.3 per thousand live births, but still very different to the other regions of the world. And this is all really about positive ascertainment. If we look at this paper, we can see that there has been an increase in the global prevalence across that same period, but this has really been very different in the different regions of the world. So if we look at North America, it stayed very stable. If you look at Europe or Asia, it's slightly increased, but in Africa, there's been a dramatic increase in the global prevalence if you just look at school-age children. And this speaks to the fact that we're only making that diagnosis once they get into school. So it's sort of 5 to 10 years behind the diagnosis in neonatal early childhood that's happening in the other regions of the world. So Africa has got a very different population and a different cohort to the ones that we see in other parts of the world. And this actually threatens the Sustainable Development Goals. This was a wonderful editorial written by a colleague, Bayra Rousseau, speaking to how congenital heart disease in Africa, as this increased ascertainment occurs, threatens the Sustainable Development Goals. It's important to remember that Africa is not just one country. Africa is 54 countries, and each of those countries are very different, not only from each other, but also from within each other. This is a horrible photograph, an aerial photograph taken in South Africa, where we see a township on the right and a suburban residential area on your left. And it gives you an impression of what is happening just within one neighborhood in Africa. Africa is ridden with examples of desperate inequality. And South Africa has the Gini coefficient that is the highest in the world, as being the most unequal country in the world. We also have this dramatic diversity of genetic preferences, which then actually impact when we think about this also in terms of congenital heart disease. I often don't want to speak about priority setting in congenital heart disease when we have this extremely fantastic series authored by Bistra Geleva and the Children's Heart Link team. And they focus on 4 areas to look at the priorities. So first, the case for the invisible child, with important success stories, then in finding the invisible child, the burden of disease, treating the invisible child, human resources for health, and voice of the invisible child, a call to action. So I'm certainly not going to repeat that. Bistra is the person who would do that far, far better than I. And I'm going to look at a slightly different approach. But that approach also incorporates those 4 priorities. So often we think of it in terms of a young baby who's undergone congenital heart disease surgery, and that's really focused on the individual. There's also this other way of looking at it where we look about health equity and how we close the gaps in healthcare disparities, interventions, and research as we think about children within the non-communicable disease spectrum. And hopefully we'll address that in some of the areas that I'm going to address as well. I'm going to use this framework, which speaks to a children-centered approach with someone born with congenital heart disease, but to understand that that's a life course approach and includes an infant, a child, an adult, and then an aged person later on in life. I'm not going to be able, in the short time that we have, to be able to deal with every nuance, but bearing in mind that this is the greater framework that we're looking at. Important to understand when we're looking at congenital heart disease and the individual base, we're looking at early diagnosis, timely management, but of course, lifelong care. The family and the immediate surroundings, also very important, where we understand heritability and risk, we train caregivers, and we consider mental well-being in the child and the family. With the community, we are focusing on social determinants of health, resource allocation and protection, and ensuring access and infrastructure. And then finally, state and national policies, where we focus on national action plans, prioritization of childhood onset heart disease, and hopefully put it all together in the end. So if we start with early diagnosis, timely management, and lifelong care, one of the things to consider is pulse oximetry pre-discharge screening. Here's 2 studies, one from the Western Cape, South Africa, and another more recent and more comprehensive study looking at pulse oximetry screening in Tanzania. Both of them focus on diagnostic accuracy, sensitivity, and specificity, but remind us of the unique variances in a low resource health setting. I looked at this with my colleague Balu from Kerala in India many years ago, and we looked at pulse oximetry screening within the realm of then developing countries. And what we focused on and reminded people about, which still applies, is that until infants born in developing countries have access to comprehensive primary healthcare services, this includes antenatal assessment, qualified birth attendance, and postnatal examination, and only if cardiac services have improved concurrently in many of the regions under discussion, pulse oximetry screening will not change the fact that infants with critical congenital heart disease will continue to be missed and die, many undiagnosed. Another area that we're focusing is, of course, the health workforce. This is a paper that was recently published looking at Africa following a national level survey and what are our levels of cardiothoracic surgeons and pediatric cardiologists per million population. You can see recommended for cardiac surgeons is 1.25 per million, and we have 0.04 across our continent. The recommended number for pediatric cardiologists is 2 per million, and we have 0.17 pediatric cardiologists per million population, which puts us very much into perspective. How are we training these individuals? More than half of our respondent countries to the survey report no fellowship training program at all. There are 21 cardiology fellowship programs, training about 2 per year, and 21 surgery programs training about 3.5 per year, which will not make up for the gap that is required. And many of them don't offer a full service, as you can see on the right-hand side. What is the result of this? Well, part of the problem, for example, is local teams able to perform cardiac surgery, even though when we look at this very interesting paper from Nigeria, we see that the COVID-19 epidemic changed this dramatically and allowed for quite rapid training of local teams. So if you look at the first part of the graph, you see the gray, which is complex heart disease and surgery, in the yellow color being performed with visiting teams. This is just over a period of a year from July 2019 to 2020. And then you see, of course, in March and April and May, there was now lockdown and no visiting teams could visit, and increasing amount of visits by the increasing amount of surgery by the local team, as you can see by the increasing orange bars. And by June, you see that there are complex surgeries being performed by the local team. This was a lovely paper published by Bill Novick, who may be at this meeting, and Marcello Cardarelli, speaking about how the development of the local teams at LMICs actually is a critical part of being able to address the needs in those units. This is using different mechanisms. This is from Brazil, from Sandra Matos's units around telemedicine and how this has been able to provide for local cardiology services. If we think about lifelong care, Philip Moons remind us of the discontinuity of cardiac follow-up, not in Africa, but in the world, in the US, in Canada and EU, showing just how significant that could be, all the way from 22% as much as 33%. So the problems with lifelong care exist globally. And if you look at the paper on the right-hand side, if you look at the follow-through, we go from 100% to 64% to 43%, and the attrition rate is as much as 39% as we go through the different age groups. And this is even more so when we think about the issues that would face a child with congenital heart disease in Africa. Yet, if we look at different ways of doing it, this is, for example, having follow-up by pediatricians rather than cardiologists. Again, Sandra Messos's team, and how Zika was diagnosed and managed across very rural spaces in Brazil. So we do need to think out of the box to be able to intervene around discontinuity of cardiac follow-up. And when we do that, we have to do so with quality at its core. So many of you on this call are part of IQIC. Thank you to Kathy Jenkins and her teams over the years for this tremendous and outstanding legacy, really, which focuses on reducing mortality and morbidity in children undergoing congenital heart surgery, but bring together tailored quality improvement programs and employing this telemedicine platform for teaching, for dialogue, and disseminating knowledge and skills. If we focus again on the next level, this is around family, and I always enjoy putting this picture on, which is done with permission from both mother and child, where you see the median sternotomy of both mom and son. And so we need to understand heritability and risk, as well as train our caregivers and ensure well-being. And so if we look at the genetics of congenital heart disease in sub-Saharan Africa, these are 5 papers that were recently published at different time points, which focuses on the kind of patients that we see, the syndromes, and also the mutations. And wonderful to note that there are new papers in this area, which has focused on different areas on our continent. Our Protea project focuses on the genetics of congenital heart disease in 3 areas in South Africa as well as in Namibia, and reminds us that these are very different for Africa, considering the huge amount of genetic variability and diversity. As we look at this area, we also think about cardiobstetrics. We think about the mother with heart disease, and we also think about the baby with heart disease in utero, and how we understand and recognize the unique issues of cardiovascular disease in pregnancy. And so this gives rise to the need for cardio-obstetric teams and contemporary topics in cardio-obstetrics. This has become a real issue in the global north, simply because more and more of our population are growing up and now are wanting to have their own families, despite the fact that they have from univentricle situations all the way to mild cardiovascular disease that still affects them in pregnancy. And then, of course, you still have, especially in the consideration of our continent, those with complex congenital heart disease, such as tetralogy of Fallot, that is unoperated. We also have to think that there's a different understanding of mental well-being in those diagnosed with congenital heart disease and those growing up with a sibling or a child with congenital heart disease. So 2 very interesting papers here. One from the Cardiac Neurodevelopmental Outcome Collaborative, Understanding Parent Mental Health and then Family Functioning following the diagnosis of congenital heart disease. And on the right, this comes from the new ESC guidelines linking mental well-being and mental health issues with cardiovascular issues. And we know that one of the long-term issues relating or complex complications relating to congenital heart disease is things like heart failure. So there are multiple by behavioral pathways linking these two, and psychological pathways that I'm sure you can recognize in your patients or your families that have encountered these. If we go back to our schematic, we're moving on to community, and this is the understanding of the of social determinants of health, resource allocation and protection, and ensuring access and infrastructure. It's more than just social determinants of health, it's also socio-economic factors, it's our physical environment, which leads on to our health behavior and ultimately our health care. And if you can look at the schematic on your left, probably at least 50% of what goes into our health relates to our physical environment and socio-economic and political determinants of health. And so we need to move beyond the downstream, how it affects our individual patient, our midstream, and then to upstream. And this is our community impact. These are strategies and tactics that we need to address so that we can ensure the better or the best possible outcome for our participants. One of those is about infrastructure. And again, from the Aldersley paper, we look at the type of cardiac service that our continent has. This is just focusing on interventional pediatric cardiac services. Wonderful to see far more green on this slide than red that we had previously. But if we look at it very carefully, only 40% of the respondents were able to provide a fully fledged pediatric cardiac service. And many of them, for example, did not have cardiopulmonary bypass, anesthetics, or both interventional and non-interventional cardiac services. This was a graphic that came out in 2019 that really has resonated with people across the world in terms of cardiac surgery. This was perhaps more predominantly adult cardiac surgery, but what it did show was that there was reduced access to experienced pediatric cardiac surgeons for complex procedures, minimally invasive techniques were rarely seen on our continent, and post-operative care that needed to be tailored to the specific needs of children was not available. Draw your attention to the fact that there are 11.1 cardiac surgeons per million population in Germany and 0.06 in Nigeria. This was a wonderful paper led by Baba Hassan. I think some of the people on this call will be in the audience today, where we looked at the recommendations for developing safe and effective pediatric and congenital heart disease services in the low and middle income countries. And this is a way on the side to demonstrate this, looking at 4 particular areas: human resources, services, infrastructure, training, and health data, and to try and get an understanding of that using this depiction. So the recommendations were at 5 different centers, level 1, 2, 3, level 4, and level 5. We've talked about these numbers before. So if we look at those service levels, the 96 institutions that answered our survey were ranked on a composite score according to Hassan's recommendation. We didn't have a single level 5 center, and 8 level 4 centers, of which 5 were from Southern Africa, 2 from Northern Africa, and 1 from Eastern Africa. And then putting them into this kind of radar plots where we stratify them again into the 5 areas, and noting that the extent of the polygon along each axis represents the proportion of institutions in that sub-region that met a specific category criteria. And any asymmetry indicates imbalance or disparities between the different categories. And so if you look again, you see very clearly that there is marked asymmetry. That's very clear. There is some measure more than 50% of health data. This is again in Central Africa and probably a little bit in Southern Africa, but generally it's an extremely asymmetrical polygon. So 33% have got level 4 or 5, but only 60% had health data infrastructure to enable quality control measures to be implemented. This was a recent call in terms of protection systems for children in all contexts, speaking to data and evidence, child and community participation, continuum of services, human and financial resources, governance and coordination, and policy and legislation. What about active child protection? This is from South Africa. And again, 10 ways to actively promote child protection. We declared on Friday from our country that gender-based and children-based violence is a national disaster. That we had to declare such a thing is a blight on our country in itself. So moving ahead now to the final part, and this is national and state and national policies. And it speaks to national action plans, prioritization of childhood onset heart disease. And so we need to know and be aware of that children's rights should be in national action plans. This is one on business and human rights, published by UNICEF. Really important to note this. There is a national childcare and protection policy from South Africa. This was published in 2019 and extended to 2025. I'm not aware of the fact whether it is planned for 2025 to 2030, and I'm also not aware if we've achieved all of the plans that were put out in this paper in 2019. This is one from Malawi, where we look at the National Action Plan for Vulnerable Children in Malawi, and whether any of these have speak to prioritization of childhood onset heart disease. I can't answer that, and I wonder if any of the participants in the audience listening could answer that as well. Especially, could you answer it for your own country? So we have the Washington, D.C. call to action on addressing the global burden of pediatric and congenital heart diseases. For those of you who have not looked at it, here's the QR code, and we ask for 4 particular areas, which once again links to those wonderful the Invisible Child series. So increased capacity to care for children or people with pediatric and congenital heart diseases, building the pediatric and congenital cardiac disease workforce, financing cardiac critical care, and then closing the data gap. So in summary, and again, I thank you very much for allowing me the opportunity to present. We focus here on children with childhood onset heart disease, early diagnosis, timely management, and lifelong care, understanding the heritability and risk, training caregivers, and ensuring well-being. We address the social determinants of health, resource allocation and protection, and ensuring access and infrastructure. And then finally, a priority is a national action plan, and in their prioritization of childhood onset heart disease. Nelson Mandela said there can be no keener revelation of a society's soul than in the way it treats its children. Thank you very much for the Global Forum Humanitarian Medicine in Cardiology and Cardiac Surgery, as well as the Symposium for Pediatric Cardiology and Cardiac Surgery for what you do in this particular regard. Thank you for the invitation and the kind attention. And again, my apologies for not being in person, and I wish you all a wonderful meeting onward. Thank you.